So, hello everyone. I'm Colin Davidson. I'm president of the College of Optometrists, and continuing in our sessions of talking to the devolved nations governments, I'm delighted to be joined by Poonam Sharma from NHS England today. So, Poonam, welcome. Thanks for taking the time out of, I'm sure, what's a really busy schedule to join us to chat this afternoon. I think it would be great just if you could maybe give us a little bit of background as to what your role is and your key responsibilities and how that relates to optometry in England.
Yeah, no, thank you, Colin, and thank you for this opportunity. So I am an optometrist by background, and I'm also an optometry advisor for NHS England and Improvement. And I've probably been in that role for approximately 16 years or so now. And I suppose, as you appreciate, as NHS England has changed, and more importantly, the organisation has evolved, so has the role. But in general, I provide clinical advice and support to eye health matters, a range of eye health issues to the organisation. Significant proportion of that is around clinical input to the provision of general ophthalmic services. And I suppose there's also responsibility attached to the role in ensuring that our population's eye health needs are met and continually reviewing that. But I suppose in today's context for today's conversation, I've been supporting NHS E&I in its COVID response in terms of eye care.
Okay, great. Thanks for the background. It's really useful for anyone listening just to get that overview. I know a lot of organisations have a risk register and they plan for the kind of the worst possible scenario. I don't think anyone could really have foreseen the way that things have gone over the last few months. So, as far as NHS England and NHS Improvement have been, what were the kind of priorities and actions that you identified that were important to take into account looking after the eye health of the nation?
Yeah, so I suppose it's probably helpful to just briefly explain the commissioning structures in England, how services are commissioned, and it's probably kind of give the rationale behind the decisions that were made and the actions that were taken. So NHS England and Improvement is the commissioner with responsibility of direct commissioning of general ophthalmic services via a mandatory or additional services contract with directly with optical practices, our contractors. But any extended primary eye care service is commissioned by local clinical commissioning groups. And these CCGs are now forming integrated care systems to work and be able to commission on a larger and a wider footprint. But in essence, anything over and above GOS, so repeat measures, minor eye conditions, or monitoring, is commissioned at a local level by the CCGs. So I suppose, very early on, as soon as the pandemic started, I suppose the key driver to all our decisions has been what's in the best interest of the patients and how can we maintain eye health in the COVID world, and that's changed throughout the phases. So early on in the pandemic, when we moved to a national lockdown, but the right thing to do was to cease all routine eye care, and due to the risk of transmission. But we also recognise that we still need service provision in primary care. You recognise that there will be patients who will need new spectacles, may break spectacles, may need replacements, and they need to be able to function. So we moved to GOS essential services, which would cater for that. And practices were financially supported to be able to provide that service. So as well as that, we also acknowledge that there will be patients who need, and we need national provision for patients with urgent emergency eye care. And I suppose at that time, very early on in the pandemic, hospital eye services were still seeing emergency patients. However, a number of ophthalmology units had redeployed their clinical staff to respond to COVID. So they were working on limited clinical staff. It was really important that the right patients turned up at secondary care. And also, there were, a large number of our patients were actually quite scared to go into a hospital. That's the last place they wanted to be in. So we knew that we needed provision to support secondary care for patients with acute urgent eye symptoms within primary care. And that's not something that can be dealt with by GOS, and it needs to be provision for all patients. So NHS England and Improvement, they facilitated the development of the COVID urgent eye care service. And it's something that we're really proud of. It was a collaborative piece of work. We worked with the Royal College of Ophthalmologists, College of Optometrists, and LOCSU in developing a service model which could be implemented locally. And normally these conversations would take months, and we managed to develop a model within a matter of weeks. And I think that's been the pace. Just generally, we need to work at pace. And I suppose if we hadn't done that, I suppose what would have happened is by the time local commissioners would have started addressing these challenges and started having local conversations and developing service models, we would have lost weeks and we would have been in a different stage of a pandemic. And ultimately, then other patients wouldn't be able to access services, or they would have neglected their eye care issues. So I think, so when we're looking at priorities, I think the key priorities were to ensure throughout, right from the beginning, that patients' eye health needs are met, ensuring that we've got provision in primary care and supporting our contractors. So whether that was, financial support, developing a service specification for queues, so there's a service model that can be implemented, or even reducing some of the, administrative burden, like suspending the need for GOS signatures on GOS forms. So just to make it easy for contractors, and supporting secondary care. So I think those were the three key priorities, and it's always been addressing the need at the time. And I suppose that's our actions address those priorities, and that's really what's been driving, throughout the last few months.
Yeah, I think, you make a really great point that things have happened so quickly. So it was really important to develop services in a short space of time as well. And queues, I think, has been something that I'm not sure it's been sort of widely commissioned, but I think, would you say it's been a useful addition to eye care services throughout the pandemic?
Yes, so I think that's one of our challenges, the commissioning structures that we have in place. I think where there were minor eye condition services, and I think that's over 50% of the CCT, there were minor eye condition services in place. There it was slightly easier to just change over to a queue service, which was, move over to a remote consultation and broaden the scope of what can be seen, and see, higher risk patients within primary care. I think the challenge has been where there wasn't any service, because again, you've got to start those conversations. And in some areas that's been, still fairly quickly, you've rapidly been able to put something in place, but there are in some areas that those conversations have taken a bit longer. From my understanding, those conversations are still taking place. So yes, I think that's, due to the challenge of, the way services are commissioned, and the responsibility sits with the CCG. I suppose going back, we did initially explore if we could commission queues nationally, national service specification and commissioned nationally. And but there were a number of complexities with that. And again, by the time we would have been able to resolve that, transfer budgets, we would have been into a different stage of the pandemic. So I think it's, it has helped move MEC services to a queue service, so addressing the need in those areas. We have been able to start conversation and start putting services in place. But yes, I think, there are other areas where, it's taken a bit longer, and something that we need to kind of recognise as we move forward as well.
Yeah, for sure. There are challenges, aren't there, really? And I think my view, talking to colleagues, is that the optometrists have responded really, really well to the situation, and to sort of deal with the way that things have been thrown at them. Is that your kind of experience as well?
Yes, no, definitely. I think, first of all, I suppose we should really acknowledge, that the last few months have demonstrated what a resilient optical workforce we have, because, like I say, just overnight, things had changed, and everybody had to adapt really quickly. So, optical practices and optometrists throughout have been providing a service, to their patients, and adapted to remote consultation, which, to be fair, was a new concept for practitioners. And then, again, very early on the pandemic, hospital eye services were risk stratifying their patients and cancelling and postponing appointments. And we had a number of anxious patients who were calling upon their optical practices to to kind of provide advice and support, and and optometrists provided that practice, provided that support and that reassurance, and then moving on, as they've been providers, they've been managing more patients within primary care, and working in collaboration with secondary care clinicians. And I've been qualified for over 2 decades now, and one of the bugbear there has always been that two-way communication between primary and secondary care, not getting the feedback. But I think, the optometrists have been able to respond and work and manage their patients by collaborating with secondary care and sharing the investigations that they've carried out and discussing their cases and managing them appropriately in primary care. So that's been a positive to see. And then with queues, you've been able to facilitate independent prescribing optometrists, adding that layer, and for them to support and broaden the cases that can be managed in primary care, so they can support secondary care. But they've also been able to support primary care practitioners as well, where they could refer patients to independent prescribing practices and practitioners. So I suppose my desire has always been that optical practices and primary care optometry is seen as the first port of call for eye problems, and I think we have moved towards that. So I think optometrists have stepped up, and I think ultimately the key thing has been they need to provide a service and look after their patients, and and they've worked within the systems to be able to do that and adapt to their clinical examinations as well. So I think it's been it's been challenging, but it's been some positives coming out as well.
Yeah, I think there has been lots of positives, and I think a theme that has been apparent as I've had these conversations with representatives from the other nations is that the communication link between primary and secondary care is really vital to sort of driving things forward. Is that something maybe you could see that we could build on for future, so that our patients are even better looked after?
Yeah, I think everybody across the board, whether it's commissioners, clinicians in primary care, secondary care, have really acknowledged the fact that we've been able to manage patients, and that's a better way of managing by working with secondary care clinicians, and it's also the right thing to do. I don't think we can move back to what we were doing before COVID. So things that we've learned, we need to harness that, and it really doesn't make sense, does it, that a primary care optometrist carries out the investigations and they work up the patient, and then that's you don't make use of that, and you duplicate that in secondary care. So I think we do need to harness it, as well as the IT connectivity, where that's being utilized to transfer images to secondary care. I suppose it's probably worth mentioning, I suppose, is that pre-COVID, on the back of the long-term plan, we were embarking on a national outpatient transformation program, and ophthalmology was going to be the first subspecialty, one of the priority subspecialties, and that obviously paused during the early stages of the pandemic, but that program is recommencing, and I suppose obviously the context is different, because now the context is the lessons that we've learned and the COVID world, so it's a different context. But I think there's a positive that, at least with the lessons that we've learned, once we look at the impact and the evaluation, there's a program and a mechanism to take it forward. So I think be a shame if we lose all that learning and we go backwards, and I don't think we should, and we can. But there's also a mechanism now to take it forward through the outpatients program, which I'm hopeful.
Yeah, sometimes it takes something for you to reevaluate what you've got and then look at it and see what are the good bits, the best bits of what we've done that we could take forward. I mean, what do you think maybe are the things that we could learn and take forward into the future from all of this?
Yeah, so I think for us, I think definitely the working in collaboration with secondary care, the two-way communication, because that's something that we've kind of lacked before COVID, and I think it's really demonstrated that we can manage patients better. So I think we need to build that within our eye care services. We have, pre-COVID, we have had an issue with IT connectivity, not being able to, refer directly to secondary care, not be able to share, images and, our assessments that we've carried out in primary care. And I think that's something that we need to, build on and kind of maintain and retain. And I think also recognizing the higher qualifications. I think, again, recognizing practitioners with higher qualifications, whether it's independent prescribers or other higher qualifications, how they can support secondary care. And there are issues, aren't there, that as hospitals are, returning back, and they have got a backlog of patients that appointments that they've cancelled. So again, or postponed really. And I think that's something that primary care optometrists can really support secondary care in managing and support those patients in primary care as well. So I think there's a lot we can build on. And I think we shouldn't lose that. So I think there's a lot of positives as well, and we just need to make sure that we harness that going forward.
Yeah, there's lots of, again, familiar themes with the other nations as to how optometry can help going forward, how maybe higher qualifications can be something that can help to manage patients better in community. So it's really it's great to hear that, and I'm sure our patients will be well looked after in future. So Poonam, thanks very much for your time this afternoon. I really appreciate it. It's been great to chat, and maybe we can carry these kind of conversations forward in future. So thanks again.
Thank you, Colin. Thank you to the college for all this support as well. Thank you very much.